CNS pathology. Seizure is one of the most frequent symptoms of the topic of today. CNS pathology is a very wide field, and today we will speak mainly about tumors because the other pathologies of the CNS have mainly a clinical diagnosis and very rarely undergo biopsies. The tumors of the CNS are not rare, 10 is 17 over 100,000 people per year, while intraspinal tumors are less frequent. Most of them are primary tumors, but there are also frequent metastatic tumors, especially from breast and lung cancers, because they probably have some special molecular aspects that favor the localization in brain tissue. Brain cancers are the second most frequent tumors in childhood, 20%, and most of these tumors are located in the posterior fossa, whereas in adults most of the tumors are in the cerebral hemispheres, above the posterior fossa and tentorium. Brain tumors have a unique clinical course because there is a discrepancy between histology and clinical course. There are glial tumors with benign histological features that are, however, able to infiltrate large regions of the brain and lead to serious clinical deficits and poor prognosis. Also, because of this infiltrative behavior, it's not possible to resect these lesions without compromising neurological functions. So the neurosurgeon always has to choose between a radical oncological resection or compromising neurological function. There must always be a balance between these two aspects. Any neoplasm, regardless of the histology, can have lethal consequences if collocated in a critical region like in the medulla, because the compression, also by a benign tumor like a meningioma, can cause cardiorespiratory arrest. Another peculiar aspect of these tumors is that, even if they are highly malignant, they do not metastasize outside of the CNS unless you perform a procedure like ventricular shunts. So these tumors have peculiar biology and peculiar molecular features. They can metastasize inside of the CNS but not outside. The World Health Organization grading scheme segregates tumors into 4 grades according to their biologic behavior, ranging from grade 1 to grade 4. Lesions of different grade are always given distinct names because the biology could be different even though the grade is similar. When tumors recur, they often show progression to a higher histologic grade and thus acquire a different name. For example, secondary glioblastoma results from the progression from low-grade glial tumors. Primary, de novo, and secondary glioblastomas have different molecular characteristics. These images below are sections from different parts of the brain. In different areas we have different types of tumors, and this could be linked with embryology because we have different types of tumors related to the different lines of differentiation. So different areas of the CNS, different ages, different types of tumors. Also the skull and the meninges can give rise to different kinds of tumors that impinge on the brain parenchyma and cause symptoms, and can also infiltrate the brain parenchyma. We can divide the CNS tumors into tumors of neuroepithelial tissue, so gliomas like astrocytoma, oligodendrogliomas, and ependymomas, and neuronal tumors, and also tumors of the meninges, lymphomas, and germ cell tumors. So astrocytic tumors, that are grade 2 gliomas, are the most frequent types of brain tumors in adults, 80%. They are most frequently located in the cerebral hemispheres, but may also occur in the cerebellum, brainstem, or spinal cord. Most often, these tumors appear during the 4th to 6th decade of life. The most common presenting signs and symptoms are seizures, headaches, and focal neurologic deficits related to the anatomic site of involvement. We recognize different morphological aspects in these types of tumors. We have a fibrillary astrocytoma, protoplasmic astrocytoma, gemistocytic astrocytoma. Tumors of this type are usually very poorly demarcated infiltrative tumors. Here there is not an hemorrhage nor necrosis, but there is an infiltrative growth. Here the gray matter has disappeared and there is also infiltration of the thalamus and on the corpus callosum. It's difficult to recognize the tumor macroscopically. You can visualize this lesion with cytology, especially during neurosurgery procedures, because the brain tissue is not so hard and you can smear the tissue on a slide and have a cytological evaluation of this type of tumor. This is a low-grade glioma. The tumor is not very cellular, apart from the bielongated fibrillary cells, very easily recognizable. This is the protoplasmic type of astrocytoma, and the histologic section you can see the thin cytoplasmic protrusions. On the left you can see microcystic areas are composed of proliferation of protoplasmic astrocytes. Eosinophilic granular bodies are seen in these areas. This is a gemistocytic astrocytoma. The tumor cells have an enlarged glass eosinophilic cytoplasm and eccentric nuclei, and they are full of material that is mainly constituted by intermediate filaments. In this case, the intermediate filaments are glial fibrillary acidic proteins. Intermediate filaments are cytoskeletal proteins, and we use them as markers of differentiation and origin of the cells. These glial cells, for example, glial cells, have a main intermediate filament, which is glial fibrillary acidic protein. Epithelial cells have keratin. Smooth and skeletal muscle cells have desmin. Neuronal cells have neurofilaments. Mesenchymal cells have vimentin. There are also other intermediate filaments that are specific for certain phases of differentiation. For example, stem cells or progenitor cells have a specific intermediate filament, which is nestin. So we can use these markers in order to make an inference about the origin of the cells. And this works also for tumors because they maintain the same intermediate filaments of the cells from which they originate. So if a tumor is GFAP plus positive, probably it's a glial tumor. For this reason, when we have to make a differential diagnosis between a differentiated tumor, like a glioblastoma versus a metastatic tumor, we use intermediate filaments. GFAP for differentiated cancer and cancer, and keratin for metastatic lesions. Okay, here from Wikipedia. Brain tumors carry a frequent mutation in IDH1, isocitrate dehydrogenase 1, and sometimes also IDH2. Mutations in IDH are found in brain tumors, but not only. We have colorectal cancer, 1% brain tumors, 90% of oligodendrogliomas, and 70% of astrocytomas. Acute myeloid leukemia, 20%, thyroid cancer, 15%, chondrosarcomas, 75%, cholangiocarcinomas, 16%. Why is this mutation relevant? IDH is an enzyme that regulates the production and utilization of alpha-ketoglutarate in human cells. For enzymes, IDH1, IDH2, IDH3, and GDH can produce alpha-ketoglutarate, which is used for separate pathways: TCA cycle, anaplerosis, fatty acid synthesis, protein nucleic acid hydroxylation. The mutant form doesn't produce alpha-ketoglutarate, but D2-hydroxyglutarate, and the presence of this substance can shift some of the metabolic cycles and this shift, as a profound consequence, leads to the inhibition of histones and DNA methylation and other epigenetic deregulations. Therefore, this mutation is very relevant in the pathogenesis of these tumors, and it's the most frequent mutation found in astrocytomas. Can visualize this mutant protein utilizing a specific antibody that recognizes only the mutant form. So we can detect this mutation by sequencing or IHC, and you can see the presence of the mutant protein in this infiltrating astrocytoma. This is a plastic oligodendroglioma. There are now some new drugs that are able to block this mutant protein. They are not yet in clinical trials, but we have promising results in animal models with this kind of mutation. This mutation is frequent in astrocytomas and very rare in glioblastoma, especially in the primary ones, whereas in secondary glioblastomas it's frequently found, since they derive from low-grade astrocytomas. There is also new data regarding the different sensitivity to the different drugs if a tumor carries this mutation. There are other types of astrocytic tumors. We have pilocytic astrocytoma, pleomorphic xanthoastrocytoma, subependymal giant cell astrocytoma. Pilocytic astrocytomas, grade 1 to 4, are distinguished from the other types by their pathologic appearance and relatively benign behavior. They typically occur in children and young adults and are usually located in the cerebellum, but may also appear in the floor and walls of the third ventricle and the optic nerves. These tumors grow very slowly and, particularly in the cerebellum, may be treated by resection since they are well demarcated. However, in other locations it's impossible to have a resection because of the possible consequences. This is the optic nerve. You can still resect the tumor, but the consequence is severe, that is blindness. This is another example of this kind of tumor in the cerebellum. This is a large tumor compressing the structures but still very well demarcated. And this is a smear of the tumor. So this tumor is usually well demarcated and non-infiltrative like other astrocytomas. The term of pilocytic means that the cells are elongated. The main features of pilocytic astrocytomas are the most frequent location, the optic nerve, optic chiasm, hypothalamus, basal ganglia, cerebellum and brainstem. There is frequently the accumulation of eosinophilic granular bodies, which means deranged metabolic activity in cells. We have Rosenthal fibers, mainly due to accumulation of GFAP. A Rosenthal fiber is a thick, elongated, corkscrew, worm-like or corkscrew eosinophilic bundle. We have GFAP positive. There are frequently regressive changes in pilocytic astrocytomas, like some forms of necrosis that are, however, found in grade 4 tumors, so very aggressive ones. Pilocytic astrocytomas are highly vascular tumors. This is usually an ominous sign because it's normally related to grade 3 and grade 4 tumors. For example, glioblastoma is the most vascularized tumor and it's a great producer of VEGF, and so the vessels in glioblastoma are quite unique. PA are vascular tumor. Pilocytic astrocytomas are vascular tumors but with limited endothelial proliferation, which means that in this case high vascularization is not associated with a bad prognosis. Other features that are relevant, especially in pediatric low-grade gliomas, are that most of these gliomas carry a BRAF mutation. The types of BRAF mutations are different. In pilocytic astrocytoma, the most frequent alterations is a rearrangement on 7q34 between BRAF and a gene centromeric to BRAF, KIAA1549, producing a fusion gene. In other gliomas, the other way to switch on BRAF is the constitutively active valine-to-glutamate point mutation V6009, which activates MEK without first needing upstream RAS phosphorylation. Both the rearrangements can be visualized using FISH. The consequence is a scheme of alteration that is common in most human tumors. The one in BRAF is the classic mutation that activates the MEK-ERK pathway that is implicated in a lot of tumors. This is the normal pathway. We have a GF growth factor that activates a receptor tyrosine kinase, which activates RAS, which activates BRAF, which activates MEK, which activates ERK, and the signaling pathway goes on until it leads to growth and survival or differentiation. You can have very different types of alterations and different points of the pathway. But the overall result is the constitutive activation of this signaling pathway, which then leads to cell senescence and derangement. Identifying these molecular alterations in brain tumors is important because this might be a new way to treat them. Mutations in BRAF, which are several, are rather frequent both in pediatric and adult gliomas. There are drugs that target BRAF, other drugs inhibiting MEK, ERK, or other components of the pathway involved in BRAF abnormal signaling. Anaplastic astrocytoma grade 3. Is the tumor with more densely cellular composition and greater nuclear polymorphism. It has very bad prognosis. The presence of frequent mitosis is a hallmark of this type of tumor. Moreover, anaplastic astrocytoma is frequently vascularized. The proliferation rate is high. This is a K167 stained image. In low-grade gliomas, 1–2% of cells are stained with Ka67, whereas in the anaplastic, usually more than 10–20% of cells are positive. In anaplastic astrocytoma, there is no necrosis. The presence of necrosis means that we are dealing with another type of tumors, the glioblastomas. Glioblastoma grade 4. Diagnosis of these tumors is usually made by imaging. Imaging is indeed quite sensitive and specific for the classification and grading of this kind of tumor, as it can describe the quality, the characteristics, the type of tissue, and also the vascularization. It's not possible to resect this tumor. You perform stereotactic. If it's not possible to resect this tumor, you perform stereotactic. So it's not possible to resect this tumor. You perform stereotactic biopsy. With special equipment, you pick up a small fragment of the tissue. Sometimes there is a discrepancy between what you see in a stereotactic biopsy and on imaging, for example. If you do not take the tissue in the right sample, in the right place, so you might classify it at a low grade while imaging suggests that it is a high grade. This may result from a biopsy of an external area or a non-proliferating area of the tumor. Therefore, you have to always put together imaging, clinical presentation, stereotactic procedure, and histology. The glioblastoma is the most common tumor in adults and is resistant to therapy, surgery, radiation therapy, and chemotherapy. Life expectancy is 12–13 months, mortality is about 97%, and recurrence is common after surgery. The histological appearance is similar to that of anaplastic astrocytoma, but with the presence of necrosis and vascular or endothelial cell proliferation. There are also some variants, giant cell glioblastoma and gliosarcoma. These are samples of glioblastoma. As you can see, it's vascularized, hemorrhagic, and necrotic. These are the main characteristic features of glioblastoma, so vascularized, hemorrhagic, and necrotic. This is a glioblastoma involving both hemispheres and passing through the corpus callosum. This image shows the butterfly aspect of this lesion. This kind of tumor features a characteristic type of necrosis called palisading necrosis. It's characterized by areas of proliferation whose center is necrotic. The morphology is usually very atypical. The biggest and the most abnormal cells that we can find in human tumor are in glioblastoma. Giant cell glioblastoma was originally called monstruocellular sarcoma because of its huge multinucleated cells, which are actually the biggest cells that you can see in a human tumor, measuring 300–400 micrometers in diameter. In some cases, the tumor looks like a sarcoma with a spindle cells, and sometimes there may even be a mixture glioblastoma with sarcoma. Probably it's the vascular component that transforms into a sarcoma. How does glioblastoma arise? The precursor cells are astrocytes or precursor stem cells. The de novo primary glioblastoma is probably a direct transformation of these cells. The most frequent alteration is loss heterozygosity at chromosome 10q, AGFR amplification, p16 deletion, p53 mutation, and p10 mutation. Secondary glioblastoma arises from low-grade astrocytoma where the TP53 mutation is frequent. The final alterations are similar in both outcomes. Still some differences are present, but there are two main pathways from which glioblastoma may develop, primary or secondary. The prognosis is slightly different between primary and secondary astrocytoma. The worst prognosis is for primary. The Cancer Genome Atlas project is an international consortium composed by different institutions all over the world with the duty of deep sequencing different types of tumors. The glioblastoma was part of the project. The samples were collected from 17 centers on which they performed Sanger targeted exome and whole genome sequencing, and then DNA copy number evaluation, DNA methylation, MRI sequences, and so on. Afterwards, they put all this data together, and last year they published on Cell the results. This is an impressive evaluation of these tumors, and they confirmed some of the data that were already present in the literature. The most frequent mutation, present in almost 90% of glioblastoma, is an alteration in the tyrosine kinase pathway, especially in EGFR. Alterations in EGFR are also common in other types of tumors, but in glioblastoma it has peculiar molecular mechanisms. Other alterations were identified in this pathway, in the pathways that control the tyrosine kinase pathway. By gene profiling, they also distinguished different types of glioblastomas. Glioblastomas from the morphologic point of view are different, and different morphologies correspond to different molecular signatures, different molecular landscapes. They have been divided into proneural, neural, classical, and mesenchymal. This further classification of glioblastomas at the moment has no relevant clinical implication. The only relevant information is that the proneural and neural types seem to have a worse prognosis. However, it is important in order to understand the molecular mechanisms behind the pathogenesis and hopefully to identify molecular targets for the treatment of this lethal tumor. Pleomorphic xanthoastrocytoma. It's a tumor that occurs specifically in the temporal lobe of children and young adults, usually with a history of seizures. It's a grade 2 and the survival at 5 years is 80% if the excision is complete. The morphology seems quite anaplastic and pleomorphic, characterized by very abnormal cells, but with very low proliferation. This tumor as well as has a very high frequency in BRAF mutation. Oligodendroglioma. It's important because it has specific morphological, imaging, and molecular features. Oligodendrogliomas represent 5 to 15% of gliomas. They are most common in the 4th and 5th decades, and they are usually preceded by several years of neurologic complaints, often including seizures. Oligodendrogliomas occur most commonly in the cerebral hemispheres, with a predilection for white matter. Calcifications are frequent and can be recognized on CT scan, so the radiologic diagnosis is often quite correct. Common genetic alterations are loss of heterozygosity for chromosomes 1p and 19q, seen in up to 80% of cases. It has a long history and often progresses to a more aggressive lesion. These type of alterations are relevant for therapy because they are linked to higher sensitivity to chemotherapy. Average survival is 5 to 10 years. This is a fragment of brain, gray matter. The lesion's boundaries are not well demarcated and there is an infiltrative growth of the cells in the white matter. Oligodendrocytes frequently surround, invade, and infiltrate the neurons. Here you can see calcifications which are evident on images. Ependymal tumors arise next to ependymaline ventricular system. In the first 2 decades of life, they typically occur near the fourth ventricle and constitute 5 to 10% of the primary brain tumors in this age group. In adults, the spinal cord is the most common location. Tumors in this site are particularly frequent in the setting of neurofibromatosis type 2. So the ependymal tumors are ependymoma, anaplastic ependymoma, myxopapillary ependymoma, subependymoma. Posterior fossa ependymomas often manifest with hydrocephalus secondary to obstruction of the fourth ventricle, and CSF dissemination is a common occurrence. Posterior fossa lesions have the worst overall outcome, particularly in younger children, with a 5-year survival of roughly 50%. The clinical outcome for completely resected supratentorial and spinal ependymomas is better. This is the ependymoma. These are the so-called ependymal rosettes that are different from other types of rosettes. You have this area with the vessels inside and cells around. They are columnar cells arranged around the central lumen. Another choroid plexus tumor can be a papilloma or a carcinoma. Another category of tumors are the choroid plexus tumor. The most frequent is the choroid plexus papilloma, but we have also carcinoma. You can see the structure, the papillary tumor lined by a benign epithelium and the fibrovascular core of the papillae. The lateral ventricles are the most common site, followed by the fourth ventricle. Choroid plexus papilloma is usually a grade 1, while choroid plexus carcinoma is usually a grade 3. This is an epithelial tumor with cytokeratin. It's not usually present. Cytokeratin is not usually present in other types of tumors. It usually have GFAP, as I told you. Pineal tumors then are very rare. Medulloblastoma is a tumor that occurs predominantly in children and localizes exclusively in the cerebellum, by definition. Both neuronal and glial markers may be expressed, but the tumor is often largely undifferentiated. While morphologically is quite a homogeneous type of tumor, the Cancer Genome Project highlighted that there are 4 different molecular types. It's highly malignant and the prognosis for untreated patients is very poor. It's extremely radiosensitive and with total excision and irradiation, the 5-year survival rate may be as high as 75%. However, radiotherapy in brain in children has very important side effects, such as low stature and or low level of cognition. To have a chance of curing this tumor, you have to irradiate the whole brain because this tumor diffuses along the liquoral spaces, even if it doesn't metastasize outside the CNS. These are the characteristic neuronal Homer-Wright rosettes. Like in the early phases of brain development during embryogenesis, the cells, undifferentiated and with very high proliferation rate, are arranged around a center and you don't have a vessel inside. You can see the fibrillary projections of the cells. Sometimes you may see some forms of palisading. A variant, especially in young adults, is the nodular form of this type of tumor. This section is stained with neuronal marker synaptophysin. You can see that some parts are undifferentiated and some parts have nodular growth. Medulloblastoma is the most frequent embryonal tumor of the CNS. The other embryonal tumors of CNS is the neuroblastoma, which can arise also in hemispheres. Medulloblastoma is not a single entity, at least from a molecular point of view. 4 types are now recognized. The histology in every group is the classic or very rarely the large cell anaplastic or the nodular desmoplastic. The main alteration in group 1 is in the Wnt pathway, that is, in the beta-catenin. The sonic hedgehog alteration in PTCH1 is the most frequent alteration in group 2. In group 3, mutations are present in mixed signaling. In group 4, we have the so-called neuronal signature. In this type of tumor, as well, different alterations from a molecular point of view may guide to the identification of different targets for therapy. These are the most relevant institutions involved in this study. Recently, in group 3 and 4, researchers have discovered an unusual type of molecular alteration called enhancer hijacking. This new type of mechanism leads to the mutual exclusive activation of the growth factor independent 1 family proto-oncogenes GFT1 and GFI1 and GFIB. Somatic structural variants juxtapose GFI1 and GFI1b coding sequences proximal to active enhancer elements, including superenhancer instigating oncogenic activity. Meningeal tumors. Meningoendothelial cells may give rise to different types of tumors. The most frequent is the meningioma. Then there are mesenchymal tumors, but they are much less frequent. Other types of tumors may arise in the meninges. Meninges can harbor melanocytes, also melanomas may arise in the meninges. Meningiomas are usually benign tumors attached to the dura and arising from the meningothelial cells of the arachnoid. Meningiomas may be found along any of the external surfaces of the brain, as well as within the ventricular system, where they arise from the stromal arachnoid cells of the choroid plexus. The most frequent genetic alteration is loss of chromosome 22, especially the long arm. The deletions include the region of 2q12 that harbors the NAF neurofibromatosis type 2 gene, which encodes the protein myelin. Meningiomas are a common lesion in the setting of neurofibromatosis type 2. The other tumor with alterations in the neurofibromatosis type 2 gene is the acoustic schwannoma. 60% of sporadic fibroblastic transitional and paraepsanmomatous meningiomas harbor mutations in the NF2 gene. So these are the most frequent locations meningiomas. Parasagittal, free convexity, falcine, olfactory groove, supracellular, sphenoid ridge, and foramen magnum. So tumors of the meninges can be tumors of meningoendothelial cells like meningioma, typical meningioma, anaplastic meningioma, mesenchymal non-meningothelial tumors like fibrosarcoma, rhabdomyosarcoma, hemangiopericytoma, primary melanocytic lesions like melanocytoma, malignant melanoma, meningeal melanomatosis, and tumors of uncertain histogenesis like hemangioblastoma. The morphology is not very exciting. If there is necrosis or mitotic activity, we talk about a typical meningioma. Sometimes also benign lesions can invade the brain. Hemangioblastoma. Highly vascular neoplasms that occur as a mural nodule associated with a large fluid-filled cyst, usually localized in the cerebellum. They are characterized by capillary size or somewhat larger thin-walled vessels with intervening stromal cells of uncertain histogenesis, characterized by vacuolated, lightly pus-positive, lipid-rich cytoplasm. Moreover, they are frequently associated with von Hippel-Lindau disease, so patients with this kind of pathology may have renal tumors, but also cerebral hemangioblastoma. So this is the lesion, usually a cystic lesion with a mural nodule. CNS lymphomas. Primary CNS lymphomas are a small but very relevant fraction of lymphomas. They account for 2% of extranodal lymphomas and 1% of intracranial tumors. The most common CNS neoplasm in immunosuppressed individuals, including those with AIDS and immunosuppression after transplantation. In the pre-antiretroviral era, it was a very frequent pathology in patients with HIV infection, while now it's much less common. In non-immunosuppressed populations, the age spectrum is relatively wide. The frequency increases after 60 years of age. This is interesting also from a biologic point of view because primary CNS lymphoma distinguishes from other types of lymphomas. Lymphomas arising outside the brain rarely metastasize or localized in the brain, with one exception. That is testis lymphoma. Primary brain lymphoma is often multifocal, frequently causing hydrocephalus, and the diagnosis is usually made by stereotactic biopsy. It's important to remember that these patients usually present with acute symptoms, so they are treated immediately with steroids. Initially, this tumor is very sensitive to steroids and there is a disappearance of neoplastic cells, so if the biopsy follows steroid therapy, it is useless. So after steroids, there is a disappearance of neoplastic cells.